Part 1 of Neurological Problems Assessment. We have our cranial nerves, and they are listed in a table on page 686 to 690. I was at a conference last August, and they talked about a new cranial nerve that they found, cranial nerve 0, because it's right out of the exit. At that time, they didn't know what it did for sure. So we may have something coming along that's going to screw up all of our acronyms that help us remember our cranial nerves, but that's the future. Just be aware it's coming. The hypothalamus is responsible for temperature regulation, autonomic nervous system, reaction, food and water intake, control of the pituitary gland, your behavior, it's your master gland. Your lobes of the brain, there's a figure on page 682 and 683 that shows those. We have our cerebral cortex that's responsible for awareness, our midbrain for reflexes, the brainstem for our respirations and circulation, the frontal lobe for voluntary motor function, cognitive function, expressive language, it contains Broca's area. Your parietal lobe that's necessary for sensory function, awareness of your body parts, interpretation of touch, pressure, pain, recognition of object size, shape, and texture, temperature and vibration. It contains Wernicke's area, which is responsible for reception of language. You've got your temporal lobe for auditory, and it also contains part of Wernicke's area. Your occipital lobe, which is responsible for vision. You've got the limbic area that is for interpretation of your memories, your emotions, and your sense of smell. You've got your blood supply, and there's a figure for that on page 691 and then 692 and 3. The spinal cord, there's a box on page 694. Your neural pathophysiology is on page 677 in a box. Your neurological assessments, you're going to get your history on page 701. Your level of consciousness, your arousal, you're checking your reticular activating system. It's responsible for arousal. Your Glasgow Coma Scale, it's on page 702. Any score of 7 or below means you're in coma. Your maximum score is 15. You cannot use the GCS as labeled for children, people who are alcoholic and drunk at the time, or for spinal cord injured patients. They need to be modified, and they have done that in many instances. Your orientation to person, place, and time is not always in that order, and there's a box on page 722 that talks about categories of consciousness. Your motor function, do they follow command? Do they respond to noxious stimuli? Is there abnormal posturing? Strength, what's their reflexes like? Do they have a grasp and or a Babinski reflex? If they're lateralizing, in other words, there's a difference between the right and the left side, there's a risk for herniation. And there's figures on page 703 that show abnormal posturing, and a box on 702 that talks about your noxious stimuli. Grasp reflex in the adult shows cortical damage. In other words, if you put your hand in somebody's hand and they grab hold of it right away, just like a baby does, that means that they have cortical damage. A Babinski in someone over the age of 2 means that you have upper motor neuron lesion. And there's a picture on page 705 that shows how to do a Babinski. You want to look at your pupils. They should be equal, round, and reactive to light accommodation. That's what PERLA stands for. You cannot use that unless you have 2 eyes. I've seen residents and interns write PERLA, blind in left eye, or enucleation in the right eye, whatever. There's a figure for this on page 705. Remember that there can be 1 millimeter difference in pupil size normally, and there is with Sam up in the HPS. If it's oval, it means you have an increase in intracranial pressure, 18 to 35 millimeters. You need to check eye movement. Do they have doll's eyes? With doll's eyes, there's a figure on 707 that shows it. This is your oculocephalic reflex. Doll's eyes are a normal reaction. You anticipate that the eyes will go to the opposite side when the head is turned. In the unconscious patient, this is totally fine. If it's not present, it means you have brainstem injury. If the eyes rove, you have some brainstem injury. Your oculovestibular reflex is on page 708, and cold caloric test is there also. Now, the cold caloric test can only be done with a patient in coma, and this is where you instill 10 to 100 milliliters of ice water, and I mean ice water, into the ear. The eyes will turn toward that ear if there's brainstem function. If it turns away, it's abnormal. If there's no reaction, there's no brainstem activity, and your patient is effectively brain dead. This is only done by neurologists or physicians, not by nurses. You need to assess their respiratory pattern, and there's a table and a figure on page 709 that talks about them. You want to check their cough, their gag, and their swallow. Check their blood gases and their SaO2 or pulse ox. Their vital signs, their blood pressure. If it's increased, it means you probably have an increase in intracranial pressure. If you're decreased, it could be a terminal event. Your blood pressure is increased due to loss of control of your cerebral blood flow, which causes increased ICP. You need to check your mean arterial pressure. It needs to be at least 60. Your heart rate and your rhythm. Your pulse ox, your end-tidal CO2, your pulse pressure, and your temperature. Cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. And your CPP, your normal cerebral perfusion pressure is 60 to 150 millimeters of mercury. When it's less than or equal to 30, it means you have cell death. When your mean arterial pressure equals your intracranial pressure, there is no blood flow into the brain. Cushing's triad means you have bradycardia, increased systolic blood pressure, and a widening pulse pressure. This means that the brain has started to herniate into the brainstem because of that increased intracranial pressure. This is a late finding. The first symptom that you're going to get of increased intracranial pressure is a change in the level of consciousness. When you look at that figure on page 710, you will notice that in stage 1, there are no symptoms. Everything is normal. But your patient may be a little bit restless. That is the first symptom, a change in your level of consciousness. Your normal ICP is less than 15, 5 to 15. There's a table on page 718 to 19 that talks about the advantages and disadvantages of different monitoring techniques. In order to put in an ICP monitor, you have to perform a ventriculostomy to insert it into the ventricle of the brain, the subarachnoid space, the epidural space, or into the intraparenchymal space. There's a picture of this on 718, and there are waveforms on page 720. But you need to know your ICP figure on 710. Diagnostic tests for neuro, you can do an x-ray of the skull, will show fractures. X-ray of the spine will show fractures. CT scan, there's a picture on 711. An MRI can be done. Cerebral angiography, there's a picture of this on page 712. DSA is a digital subtraction angiography, and it removes any distortions that might be there. In MRA, there's a picture of this on 711. This is a magnetic resonance angiography. Your interventional angiography can be done. Your myelography is where they inject a dye into the spinal cord and then take pictures. A lumbar puncture, there's a picture on page 714, and this may take some cerebral spinal fluid in order to assess it. Your cerebral blood flow is assessed by injection of xenon dye and then doing a CT scan or a PET scan or a perfusion CT scan with iodine that contains more dye. You can do carotid duplex sonography to check the blood flow through the carotids. You can do the Doppler ultrasound, the transcranial Doppler studies. There are 3 areas of the skull that are thin enough to use: the eye, the foramen magnum, and the temporal bone, to check for lesions. They can also do a PET scan, an EEG, and there are waveforms on page 715 that looks at those. The lumbar puncture and the cisternal puncture are both done to obtain cerebral spinal fluid, And as I said, there's a picture on 714 for the lumbar puncture. The cisternal puncture goes in at C1 to C2, so they're very, to get the specimen, and there's a picture on page 714. There's a table on 717 that talks about interpretation of cerebrospinal fluid. And they can also do cerebral oxygen monitoring. Now, this is also invasive, and there are 3 different types. One is for cerebral metabolism, one is for JV oxygen saturation, and the other is for brain tissue oxygen pressure. I've not seen any of those. That's something new, and I'm not sure it's being done in this area. It may be. Neurologic disorders, coma. Coma is a symptom, but it has different stages, and there are causes for it that you can see on page 725. Some could be due to structural lesions such as vascular, tumor, abscess, or trauma. Vascular could be a stroke. Metabolic and toxic conditions include cardiopulmonary arrest, poisoning, alcohol overdose, hypertensive crisis, meningitis or encephalitis, following a convulsion, changes in your blood sugar, uremic coma, and hepatic coma. For your pupil changes, there's a figure on page 726 that you can look at. Now, non-traumatic coma has a better prognosis than traumatic coma. 30% of your non-traumatic are due to overdose. Keep in mind that if your patient has alcohol as a problem, they're developing a thiamine deficiency, which causes that coma, and you have to give the thiamine first before you try the glucose and the Narcan, because they won't respond appropriately to those. And there's a box on page 725 that contains a continuum of descending states of consciousness that you need to know. But the pathophysiology depends upon the area of brain involved. If there's damage to the midbrain, you have loss of reflexes. If it's to the brainstem, you have loss of respiratory and circulatory control. If it's to the frontal lobe, problem with reasoning and logic. This is diagnosed by CT scan, lumbar puncture, and physical exam. And you may never actually know the real cause of what's causing this coma. Coma treatment, you have to follow your ABCs. Then, as I said, you have to give thiamine first, as the coma can be made worse by giving glucose first. So if you find somebody on the street, unresponsive, not doing nothing, and you smell alcohol, you give thiamine first, 100 milligrams. Then, if that doesn't work, you do the 50% dextrose, and if that doesn't work, you then do the narcotic. That's it, narcotic antagonist. That's if the cause of the coma is unknown. Now, if you see somebody bleeding in or having a head injury, those are probably the causes of the coma. Always stabilize the neck. You don't know for sure what's going on. And treatment is supportive. 60% will die if it lasts over 6 hours and it's non-traumatic. 12% will develop a persistent vegetative state, and 3% will recover if the coma lasts over a week. Your metabolic comas have a better prognosis than structural lesions, and traumatic coma has a better prognosis than a non-traumatic. Nursing management, total care. Eye care to prevent drying and ulceration, because you don't want your patient to come out of the coma and be blind. So eye drops every 2 hours. Keep the eyelids closed, cover them with a cotton swab covered with saline. That's cheap, that's effective, it works. They also have ointments that you can put in like every 4 to 6 hours, where you don't have to do this, but that costs money. Cotton balls and saline, the hospital doesn't charge for. Coma stimulation treatment can only be done if the patient is medically stable with a normal ICP. And if so, then coma stimulation treatment does decrease the time of coma and increase the recovery. Taped voices of the family works the best as long as they get along with their family. 10 to 30 minute activities 2 to 4 times a day. But if you notice an increase in intracranial pressure, heart rate, respirations, blood pressure, seizures, you stop. Now, nursing diagnosis, find on page 726 in Collaborative Care on 727. I took care of Stephen. He was a 13-year-old who was playing with a friend of his, found a gun underneath his parents' mattress. What they were doing under his parents' mattress, I'm not too clear, but anyway, decided to play cops and robbers, and the friend went, bang, bang, you're dead, and a bullet came out and hit Stephen in the frontal lobe. And so he was in our hospital for 6 weeks in a coma that got no better, and he was on a vent. And the doctors were talking to the mother, single parent, about taking him off the ventilator, and she said, no, he's going to get better. He was a football fan. He wanted to play football. So she wrote to all the football clubs in the area. They sent jerseys and banners. He had them from the Browns, from the Detroit Lions, the Cincinnati Bengals, the Indianapolis Colts, the Pittsburgh Steelers. They were all there on the wall, and she would talk to him about them all the time. And so they decided to see if there was an area around that would do the coma stimulation treatment rehab, because he didn't need acute care any longer. And so the people from Indiana came and evaluated him and said, no, they didn't think they could do anything. And the people came from Columbus and said, no, I don't think we can do anything. And the people came from Green Springs, and they said, well, give it a try. So he went to them, to Green Springs. 6 weeks later, he walked onto our unit using a cane, but he walked onto our unit, came up to the nurse's station and said he was there just to thank us. And I told him, that he looked really good, and he said, I recognize your voice. Patients hear what you're saying to them. He recognized the voices of all the nurses who took care of them. So it's really important that you watch what you say around patients, because they can hear you and they do remember. Now, a persistent vegetative state is also not covered really well in your textbook in this edition, but it's cerebral ischemia following a cardiac arrest is the usual cause. The eyes will open if you flex the elbow. Why? I haven't the faintest idea. But they don't track objects, and they don't avoid threatening gestures. In other words, if you take your hand and bring it at your face like you're going to hit yourself in the face, most people will blink. They don't do that. The state becomes permanent if it lasts more than 3 months in a non-traumatic state, or more than 12 months after trauma. And the definition is no awareness for more than or equal to at least 1 month. Now, on the average, they live 2 to 5 years. And so it's really important that you decide on treatment ahead of time. Research says they cannot feel pain. How they know that or not, I don't know. I think they say research says that people in coma cannot feel pain. I go by subjective symptoms. If their heart rate starts to go up, their respiration starts to go up, I figure they're having pain, and I'll give them something. But there were 2 cases that I want to discuss. One was of the Florida case with Terry Schiavo. She had been in a coma for over 7 years, and the husband wanted to stop her feeding tube that was sustaining her life. And so he got that permit. The family went back to court and said, "No, you can't do that." It went all the way to our Supreme Court. They got the governor to order a stay while the court appeal system went in. You need to make your decisions ahead of time as to what you want done. I know you're all really young people, but you need to make a decision about what's going to happen. Do you want to stay around in a persistent vegetative state? Do you want to give it a certain length of time? Or do you want to make a decision? They did DC the feeding tube, and she did die. And on autopsy, it showed that she was blind. So the fact the family said that she would look at her didn't mean that she was seeing them, because she was legally blind and showed a lot of cerebral atrophy. So she didn't really know what was going on. Now, the policeman is another case. This took place in one of the Carolinas. And he responded to a domestic violence call. And they always say, don't get in between family members who are fighting. Well, he tried, and he was shot in the head and was in a persistent vegetative state for over 10 years. Now, he must have been getting absolutely phenomenal care because he did not develop a decubitus or pressure ulcer in any way, shape, or form. And one day while the patient care tech was giving him a bath, he asked, "Has my sister been in?" And she said, "Say what?" "Has my sister been in?" Well, she said, "I don't know. I'm going to go look and see." And she went out and said, "He's talking." And they said, "Nah." And she said, "Yes." And they went in, and he was totally awake and aware, but he did not remember the last 10 years. He did remember some of the things he had been told, and he was paralyzed from the waist down. He knew that his wife had divorced him and remarried. He remembered that. But he got to meet his children, who were 6 and 8 when he was shot, so now that they were 16 and 18. And he got to spend some time with them. Unfortunately, about 6 months to a year later, he threw a massive pulmonary embolism and died. But at least he got to see his family for a little while. And there are other stories in the literature of people who have had traumatic injury that do respond eventually. But the non-traumatic don't do quite as well. Brain death. In order before somebody can be determined brain dead, the person must be warm and without any drugs in their system. On EKG, as they're being rewarmed, they'll show Osborne or J waves, that are similar to the delta wave on the other side of the QRS. They show up when you're being rewarmed for somebody who's in a hypothermia. But once they're rewarmed, then you can make a determination of whether they're dead or not. This finishes part 1 of the lecture, and we'll continue whenever you click on part 2.